Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our talk tonight is Diabetic Retinal Disasters, a Roadmap to Prevention. And our speaker is Dr. Roya Attar, who serves as Associate Professor and Director of Optometric Services at the University of Mississippi Medical Center in Jackson, Mississippi. She's a distinguished fellow of the American Academy of Optometry. She assumes very pivotal roles there, including chairing the AAO Retina Special Interest Group and serving as the vice chair of the AOA Leadership Development Committee. Additionally, she leads her Optometric Society, actively contributing to discussions on best practices. Her achievements have been recognized through numerous awards, including Mississippi Young OD of the Year, Seacoast Young OD of the Year, AOA Young OD of the Year, and Women Optometry Young OD of the Year. She's got numerous accolades, is a fantastic mind and educator, and we're really looking forward to hearing what she has to say, and we're very happy to have her. So with that, Roya, please go right ahead and educate us.
Thank you for that great introduction. So from right then, I'll go ahead and get us started tonight discussing diabetic retinal disasters, a roadmap to prevention. And as Dr. Salka mentioned, I live in Mississippi, which if you think about the diabetes belt, I always like to say in Mississippi, we are the buckle of that belt. Recently, though, I would say West Virginia has surpassed us, but we're going to get that title back, I'm sure, not too long from here. So just going to start with a little bit of background about diabetes. I know this audience knows all about it, but just a quick refresher. Remember that diabetes is a chronic metabolic disorder that is characterized by high levels of blood sugar over a prolonged period of time that circulate in the blood. And this condition arises either when the body does not produce enough insulin or the insulin that it does have is not effectively working. So it's a global epidemic. It's projected to reach about 350 individuals by 2030. And there's an increased prevalence in those of non-white European descent. So very high prevalence in Native Americans, Asians, Black individuals, Hispanics, and sort of in that order. I want to go through the different types of diabetes because it's a little bit different, the different kinds that you have. We might be familiar with type 1 that you've heard about. It usually occurs of those younger individuals, usually under the age of 30. And these individuals, usually you'll see them, they'll be a little bit thinner frame, usually shorter. And it's usually due to an autoimmune mediated or some type of idiopathic destruction of the pancreas beta cells. So these individuals, the moment they're diagnosed, will immediately go on insulin. A lot of times when you talk to these individuals, they can tell you something in their history that they were very sick at one point or something happened that suddenly caused this insult to their immune system, and hence they were diagnosed with type 1. But a lot of the ocular and systemic effects are similar to what we know about type 2 as well. The main difference being that the moment that they're diagnosed, they usually go on insulin right away. Type 2 is the one that we're probably going to see the most of because this is 90% of diabetics. It's adult onset, usually after age 40. Initially, at the time of diagnosis, if they're caught early on, most are non-insulin dependent. They usually go on medication that helps to boost the activity of the insulin that they already have, because their body has become some sort of resistant to the insulin. Most are asymptomatic, and a lot of diabetics now, I actually see as most of them are diagnosed with pre-diabetes. And that's usually, I always tell that this is an opportunistic sort of time that they have, because if they, take the right steps, usually good diet and weight control, they can usually help to overcome. They control it without necessarily going on to take the medication long-term or later on moving into taking insulin. However, here in Mississippi, and like many of our patients, many of those patients have been diabetic far longer than before that they were even diagnosed. So about 20% of those at the time of diagnosis will have some form of retinopathy. Most of them will have hypertension. They'll usually have high cholesterol as well. When I was in school, I learned that about 60 to 80% will have retinopathy in about 15 or about 20 years. That has now been updated to about 15 years. And most of these patients will lose vision because of macular edema associated with diabetes. Next, I want to talk about gestational diabetes. This is a pregnant female who usually develops diabetes during pregnancy, and it usually occurs for the first time and while they're pregnant. It can happen in the second or third trimester, and it's usually managed through dietary adjustments. And it occurs about 2 to 10% of pregnancies. It's actually, fairly, I would say, more and more common. One notable thing about individuals with gestational diabetes, a lot of these individuals will have real diabetes in the future. So just something to speak to them about. Then I want to talk to you about a few other ones that you may not have seen, but you will see more. Another one called diabetes type 1.5 or LADA, latent autoimmune diabetes in adults. And this has characteristics of both type 1 and type 2. And it's 1.5. So like type 2, it's diagnosed more in adulthood and it sets in gradually, but it's also but like type 1, it's not reversible with any changes in diet and lifestyle. These individuals will look more like a type 1 diabetic. They'll usually be more skinny at the time of diagnosis, and they'll usually be on insulin as well. And then another one that's a more rare form that you may have seen or will see is called MODY, or maturity onset diabetes of the young. This one is actually more of a genetic form of diabetes, a autosomal dominant kind of diagnosis. And it's usually misdiagnosed as type 1 or type 2 because it has shared features. And usually, again, it manifests before the age of 25. One of the things about these individuals is these individuals are actually more lean too. They're also not obese. They're more lean. They don't look like a typical diabetic that we think of. And the way to really know what type of diabetes these individuals have is genetic testing. Again, because it's autosomal dominant and a lot of people have had it, you can usually track that as well. It's one of the giveaways. So diabetes has several complications. This constant hyperglycemia is the core causative agent, and it leads to things like diabetic neuropathy, nephropathy, cardiovascular disorders, and ophthalmic disorders, which is what we will focus on tonight. And about 60% of lower limb amputations in the US are actually due to diabetes. So another important thing to think about. Within the ophthalmic world, granted tonight the focus is on diabetic retinopathy, but I do not want it to be lost that diabetes can cause so many other things, some of which are written on here, including dry eyes, ocular surface disease, diabetic keratopathy, diabetic cataracts, refractive changes, extraocular movement disorders, neovascular glaucoma, papillopathy, and then, of course, very notably, retinopathy, which is where we are going to focus on tonight. So diabetic retinopathy is the most common vascular retinopathy. It is the leading cause of new cases of adult onset blindness. And I want to say that one more time. It's the leading cause of new cases of adult onset blindness. And the thing about that is many of these things are actually preventable. And that is why we are focusing on it tonight. There's ton of research in this area, lots of clinical trials. So, and lots of treatments coming out for these patients. Traditionally, there's only been things to treat only macular edema, but now there's things that are looked at now even earlier and earlier, being looked at earlier in these patients to basically stop this disease before it leads to blindness. Why are we concerned about this? Because as the population is living longer, and this incident of diabetic retinopathy is increasing as well. And as we can see here, as we mentioned earlier with the different ethnic groups, how much is increasing in every decade of life. So with that, I'm going to take a pause for our first poll question.
All right, we're going to launch it right now. Okay, which of the following is the first clinical finding of diabetic retinopathy? Microaneurysm, intraretinal microvascular abnormalities, exudates, cotton wool spot. Which of the following is the first clinical finding of diabetic retinopathy? People are rolling in here. Remember, this is the synchronous part of the virtual conference. So please reply to the polling question. Joe, is there anything in the chat box?
Just you, me, and Vanessa saying hello, as well as Steven saying hello back.
Okay.
So we were good.
All right. So it looks like most have replied. I'll display the results. You won't be able to see it, Roya, but I'll read you the responses here. We got 74% saying microaneurysm. We have 20% going with intraretinal microvascular abnormalities. We got exudates being 6%, and no one is going for cotton wool spot. So microaneurysm at 70%.
Yeah, very smart audience. Very good. Okay, so microaneurysms are the very first sign of diabetic retinopathy. So how do we stop a patient, or how do we catch this patient that has this very early microaneurysm from turning into this disaster? So similar to this patient here, here's a patient that 3 years down the path came in, had retinopathy, failed to come for follow-ups, failed to come for treatments until it was basically the patient was blind. So all of these are a form of preventable diabetic retinal disasters. And all of these patients, all of these that we see as these disasters, all of them started with one microaneurysm. And this is where they went. So how can we stop that from happening? And there's a few things. One is the importance of how to detect diabetic retinopathy, when and how to manage it, when to refer it and who to refer it, and then how to co-manage these patients. A few of the pitfalls that we will be addressing is inadequate screening or examining of these patients, inadequate attention to certain findings, and then the importance of addressing this disease in a way that the patient can understand, because a lot of times these patients, especially the ones that are lost the follow-up, it's not always because of financial barriers or access barriers. Sometimes it's really beyond the patient's conception. So that's what leads to a lot of poor compliance and follow-up. So let's start with the first part, importance of detection. So when we are examining our patients, what must our clinical exam include? Should include the type and duration of diabetes, how well their control is, glycemic control, if they use insulin or not, other related history of other vascular conditions like hypertension, sleep apnea, ocular history, if they are a smoker, any other associated complications, and then very importantly, pregnancy or if they plan to become pregnant. And that may sometimes be a difficult conversation to navigate. But it is very important for us to talk to these patients, let them know what, becoming pregnant, especially if they're poorly controlled, what that could do to the status of their retinopathy, if they have any, or if they don't, it could certainly worsen it. What must your initial examination include? Really not much different than what your current comprehensive exam includes, with the exception of some pertinent negatives. So making sure to notate if there's any type of neovascularization anywhere in the iris, disc, elsewhere, any types of hemes, noting all those, gonioscopy when it's indicated. And then very, very importantly, one of the things I said earlier on is that anyone who is diabetic, 60 to 80% within 15 years, they're going to have some type of retinopathy. But this is the other very, very important part. Once that person has retinopathy, at that point, it doesn't really matter how long they've been diabetic. The duration of diabetes is not important. After that, the most important thing is how well they're controlled. That will determine how their retinopathy will progress. So it's sort of like once they've overcome this threshold, it's their control that will determine how well they do. And in a way, when I have this conversation with patients, it's in a way to tell them in an empowerment kind of way, sort of like you have this control. And by control, I mean how well you control your blood sugar determines how well you do. It's not like it has a mind of its own. It's very important to keep that in mind as well. So going back to microaneurysms, if you ever think about microaneurysms, if you want to really nerd it down, like I said, there's really different ways that a microaneurysm can go. The body does clean it up. It's an outpouching of the retinal vessel, but a microaneurysm can lead to an intraretinal hemorrhage. It can lead to leakage, which can lead to macular edema and exudates, or it can lead to ischemia, which can lead to cotton wool spots, later neovascularization. So from that one small microaneurysm, it can go many different ways with poor control. So with that, we want to go into our next poll question.
Okay, the polling question is open. And which of the following diagnostic instruments is the most sensitive for diabetic macular edema? FA-OCTA, that's angiography, OCT, or B-scan. Which of the following diagnostic instruments is most sensitive for diabetic macular edema? FA, OCTA, which is OCT angiography, OCT, or B-scan. Sure everything is still okay, quiet in the chat box there, Joe?
It is nothing clinically pertinent. All is good.
Okay. People are being synchronous here in the virtual course, so we appreciate it. And I think we got a good response. We'll display it. And we have FA being 20%, Roya. We have 41% being OCT angiography. And we've got OCT being 37%. No one went with B-scan.
And Roy, before you move on, a question did just come in. And the question is asking, does retinopathy occur sooner in type 1.5 and MODY than it does in type 2? And is it more similar to type 1?
In general, I don't think we've seen enough to know the difference between who gets it quicker. With all of these groups consistently, it really depends on their level of control. Personally, from personal experience, I would say it's because of MODY and type 1.5 and type 1, when they get diagnosed, they immediately get treatment, so they're usually better controlled. I would say type 2's retinopathy is kind of worse, but then it's also considering they get it younger too. So it's sort of, I think we'll see over time, which is more aggressive retinopathy. But one thing that's consistent between all of these groups is their level of control. Great question.
I think we're
Yes.
good.
So the polling question, I would probably give credit for, and you can go whichever way you want with Roy, it's your question, but I'd give credit for OCTA and OCT. Obviously the B scan, OCT can pick up the diabetic macular edema. OCTA is looking at the blood vessels, but it does have the B scans in it. So I don't know. Well, I'm not sure which way you were leaning on that, but I'd probably give credit for OCTA and OCT, but 45% with OCTA and 37% with OCT.
Okay. It's OCT is the most sensitive test for detecting macular edema. OCTA is great for detecting ischemia, very good ischemia. And we're going to look at those different detection methods. So one of the other things about managing these patients is the different ways that we use to detect this disease. And one thing that's wonderful in our profession is that we have so many tools for detection. But one thing that is important to notate is that even though we have so many ways to visualize the retina, each tool, each technique has its limitations and each has its benefits. But until anyone really says any different, I do want to stress that the gold standard is still the dilated fundus exams, and all diabetic patients should be dilated at least once annually and more, depending on their level of retinopathy. So knowing the limitations and the strengths of each device is very, very valuable, especially when we have so many devices now. And sometimes there's devices now that do multiple things. So we're going to go through a lot of the devices that we have, most of us have in our clinic, starting with fundus photos. These are wonderful. They're great for establishing like a baseline, looking at progression. One thing that I really like fundus photos for is for patient education. It's so valuable to show a patient. And you can't just show them a picture of their fundus. Certainly, if they have any retinopathy, they can't appreciate it. You have to show them a picture of a normal and then show them their picture so that they can compare the difference and be able to appreciate that. A lot of people now have the ultra wide field, and the difference in that is the ultra wide field, covers much more into the periphery and can appreciate a lot more. This is especially valuable because, as we're going to see later, if you have a diabetic patient, when we think of diabetes, this is a disease mostly in the posterior pole. So if you have hemes and disease more showing up in the periphery, that's a cause for concern. Those patients usually progress much faster. So OCT, it's wonderful for quantifying retinal thickness, monitoring macular edema, looking at the vitreomacular interface, and then really being able to look at the progression with patients. This is a great way to look at how these patients look, prior to treatment, how they're responding to treatment. It's really one of the tools that has really, I would say, guided how we manage and treat patients and monitor their response to treatment.
Hey, Roya, go back one slide there. I just want to point out to the audience, when you're interpreting that OCT, there is that, remember that you have the inner retina and outer retina, and there's a loose association, and that's why you kind of see that hyperfluorescence kind of build up in that space. When you see that hyperfluorescent, you can't really tell by looking at an OCT if that is blood or exudate. It's one or the other because they both hyperfluoresce. And you can tell how dense it is because you can see the shadowing down below it. So I just wanted to point out that if you're looking for diabetic retinopathy, kind of look between that inner retina and outer retina. There's a loose association, and that's why you'll see it kind of separate. It's the photoreceptors in the outer retina. It's all the neurological wiring in the inner retina. And it's a space. And that's why you get that exudate or that blood or that fluid, which will be black in some of those, in that upper one that you see there. So that's it. Just wanted to point that out.
Oh, that's really good. Yeah, I often have residents with me in their first year residence. They've never looked at an OCT, and a lot of what we see is diabetes and macular degeneration. And one of the earliest things I teach them is, remember, usually diabetes comes from the top. You see usually the top layers, and then whereas the AMD or macular usually comes from the bottom at the level of the RPE. Quick, easy way to remember those two. Fluorescein angiography. It's great when you suspect any type of macular edema. This is the way to identify vascular leakage. This is the only way to really look at leakage in eyes with macular edema. And it's a good way to also look at non-perfusion and subclinical neo. That's really hard to be appreciated in any other way. Fundus autofluorescence. Again, this is a good way to look at hypoautofluorescence by opacities such as retinal hemorrhages. They usually show up a little bit darker. Depending on the tool that you use, the lighting may do different things. So very important to be familiar with what type of FAF machine you're using, whether it's an Optos or a Heidelberg. They kind of illuminate very differently. Ultrasound, this is very valuable if you have a patient that has a very large vitreous hemorrhage or retinal detachment or just a very opaque media that's hard to visualize. That is useful to use. So ultrasound certainly has a way as well. The OCTA, kind of the newer kid on the block, I think more and more offices are starting to get this device as well. It allows for evaluation of the deep vascular plexus. One thing that you can appreciate in diabetic patients is that they will have a larger foveal avascular zone when they start to get retinopathy versus a traditionally healthy patient. So you can really, and that's one of the best ways to really detect subclinical diabetic retinopathy. Great for looking at ischemia and areas of non-perfusion and kind of predictive neo. So if you have an area that looks ischemic, you can probably scan it again in a while, and you can also see those neovascular trees pop up. There's other ancillary testing that we still have utility of. I'm not sure how much anyone uses it, but I have it in here. There's some studies that say contrast sensitivity testing is valuable because a lot of diabetic patients test their level of ocular eye health by their visual acuity. But if you were actually to test contrast sensitivity versus traditional Snellen acuity, you would see that it's reduced, even though their visual acuity is not necessarily detectably reduced at the time. Blood pressure, do that on every patient with diabetes, very, very important. Color vision testing, there's some studies that say that color perception changes in diabetics, but it's not diagnostic of diabetic retinopathy. And then old method to use, you can even use an Amsler grid to detect early macular edema too. I certainly don't send home my diabetic patients with an Amsler grid, but you certainly can.
Yeah, one thing I'll point out there with regarding color vision is that I want to point out to the audience is that, it's probably not your Ishihara plates. I've been playing around with this test called the Rabin cone contrast sensitivity, very sensitive and picking up early macular degeneration and diabetic retinopathy. Can't really tell the difference. You just know that the color vision is being affected. So just wanted to point out that that's what the color vision that's out there. Are you going to talk about ERG testing also as an ancillary test?
I don't have that in there, but
okay. You could just add that to your list that's out there. We don't have to talk about it, but I would add ERG testing for early detection too.
I love that you brought up the Rabin color vision testing. Dr. Rabin was one of my professors, and he used to talk about that all the time, about color vision, the value of it, but hasn't really been.
while we have a break, can you just go back one slide?
Oh, sure.
Maybe point out there in the normals, you know, the superficial and deep, you can see that that's the foveal avascular zone. Okay, avascular, there's no blood flow in there. That's the capillaries that we're looking at in that inner retina. And then over there in the diabetic retinopathy, you can kind of see how it's expanding.
Yes.
So you are correct. It's picking up in a lot of clinics, and that's what it would look like.
Yep. Can you see my mouse in this?
You
platform?
can, yep, you certainly
okay.
can.
Well, duly
It's a
noted.
game changer now, right?
Now it's on now. Okay. So one thing that's very important is proper classification, which leads to proper management, and it can be very site saving. So once we detect this correctly, we have to make sure that we classify it into the correct classification. There's a few classifications. This is the most used one. It's from the American Diabetes Association with mild, moderate, and severe PDR. There's other ones from the ICO, the AAO, but they all pretty much follow the same type of protocol. You may have seen the ETDRS, Diabetic Severity Scale. No one really uses this clinically. This is more used for clinical trials and things like that. So when patients are screened, if they qualify for a study, how much they improved, this is sort of the standard that's used. And with that, I'd like to take us into our next poll question.
Okay, let me get it launched here. It's opened up. The 4-2-1 rule of diabetic retinopathy is associated with absence of non-proliferative diabetic retinopathy, mild non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy. The 4-2-1 rule of diabetic retinopathy is associated with the polls are rolling in nicely here. And what we have is 2% went with absent, 7% went with mild. We have proliferative with 35. The majority at 53% is severe non-proliferative diabetic retinopathy.
Excellent.
Well,
Excellent.
we are good on questions. And nobody's called. But while the poll was going on, I actually went onto the App Store and downloaded 2 Amsler Grid apps. It's something that is out there for patients. They seem kind of interesting, not very sophisticated, but it's easy to use. But one has a scheduled notification to remind them to look at their Amsler Grid, and they have varying degrees of information.
Excellent. Okay, so classifying these patients. So non-proliferative diabetic retinopathy, these are patients that are going to have at least one microaneurysm. Whether they have 1 or they have 10 or 20, these are going to be classified as non-proliferative diabetic retinopathy. Like I said, even 1, you put them on there as non-proliferative diabetic retinopathy, because remember, I'm going to say this again, once they have any form of retinopathy, even the smallest little microaneurysm, even if it's just 1, at this point, it really matters how well they control, because that level of control will matter how they progress in their retinopathy. Next, we have the moderate non-proliferative diabetic retinopathy. This is classified as more than mild, less than severe, which doesn't really tell us much, but in these patients have microaneurysms, they can have some intraretinal hemorrhages, they can have some cotton wool spots, some exudates. It certainly doesn't look mild. A lot more is going on. Again, granted, at this stage, both at the mild stage here that we see, And even here at this stage, these patients could still have really, really good vision. And this is why this disease is often continues to progress. But here, honestly, when I think about it, when you look at cotton wool spots, what does that mean? That's ischemia. That's an ischemic area, develops this cotton wool spot. Really, they're not far from developing neovascularization at this point. And that's why this study I thought was very relevant to put on here, because many patients can be asymptomatic until they get moderate NPDR. So as we see here, whether they have either questionable DR or mild or moderate, you know, they really have pretty good vision. And it's really not until that they progress that they notice that they have any disease, because of the same consistent thing that comes up over and over and over with all patients, diabetic or not, that patients judge their eye health, their ocular health, by their visual acuity. And unfortunately, when they do that, they don't even judge it monocularly. They judge it binocularly. So they could have really bad disease in one eye, but the other eye certainly makes up for it, and they would not know it. So severe NPDR, as the audience correctly got correct, this is when a patient has it's the 4-2-1 rule, and they could have any of these. They don't have to have all three to be severe, but they could have any of these. 4 quadrants of intraretinal hemorrhages, 2 quadrants of venous beading, which I would say of the 3, they're probably the hardest to appreciate, venous beading, and then 1 quadrant of intraretinal microaneurysms. So that's the 4-2-1 rule. And the reason I wanted to bring attention to this is that there's new paradigms in treatment that have been shown that if you start treating patients at this stage, that a lot of patients will have a better visual outcome. Because in the past, the paradigm has been, you know, we don't treat patients until they become proliferative, or if we see some type of macular edema or anything. But a lot of new treatment paradigms and studies have shown that if you start treating patients at the severe stage, then they'll have better visual outcomes. And newer studies are looking at actually treating patients in the moderate and the mild stage as well. And then proliferative is at the point where you have if you have any type of neovascularization, pre-retinal hemorrhage, vitreous hemorrhage, any of those things that you have, that's going to be proliferative diabetic retinopathy. Very importantly, when I was in school, we learned this word called clinically significant macular edema. And that's really not used anymore. That really actually was more of a term, again, used in clinical trials. The more commonly used term now that you should see and that you will see with retina specialists is diabetic macular edema. And then you will also see it further denoted as centrally involved or non-central diabetic macular edema. And what are we talking about? What's the area that's important? It's going to be that 1,000 microns right here where my mouse is right here. So a patient could have macular edema, but let's say they have it here or here, that would be a non-center involving diabetic macular edema or macular edema. They don't even necessarily put diabetic macular, it's just macular edema at this point. Or if it's center involved. And that's very important because I will tell you this, not all retina specialists will treat a patient that has non-center involved macular edema. For example, the one I work with closely at our institution does not. And sometimes it's multifactorial whether they do or not. And so that's one thing to know, again, with your level of comfort. Do you want to send that patient knowing that they're just going to be watched in the retina clinic, or will you hold on to that patient and work closely with your retina specialist? So a few of those things to consider, but in general, when it's non-center involved, it's outside these 1,000 microns. This is the AAO scale, the American Academy of Ophthalmology, again, very similar to what we just went through with the American Diabetes Association. So same type of thing. I just wanted to bring attention that there's different scales, different names, but really all within the same, not notable difference. But very importantly, that's one of the biggest pitfalls that we have to avoid. Because we may see a patient like this, and this was a patient who, I believe this was a Black female in her 30s, very poorly controlled, had been diabetic for over 5 years that she knew of, very poorly controlled, had several children. And as I looked, I mean, it looks very quiet, but based upon her history, and if you look at the vasculature, I'm looking at ischemic. You know, at this point, we didn't have an OCTA either. And I'm thinking there's some ischemia. I see a few little microaneurysms there in the periphery. So that sort of increased my index of suspicion, sent her for an FA, and lo and behold, she has proliferative disease. Had I not known to do that or thought of that with the other indicators, I would have probably staged this as mild and might have seen her a year later, or maybe less than that, given she was poorly controlled. But, and by then she could have maybe lost even more vision. So one of the things, very, very important takeaways from this is a lot of studies have found that the end diagnosis by a lot of referred patients, we are actually similar to how we always say, particularly optometrists underbill. We also underdiagnose. We also understage. So the majority of the patients that were sent for initially referred and classified as severe, the majority, look, 35% of them actually have proliferative disease, and 39% were severe, but 35% really had proliferative and a few were less. So better to overdiagnose than underdiagnose. Same thing here. Here's another patient. Both of these patients actually have proliferative disease, but they look very different. Diabetics look very different. I call the more bloody retina is actually much easier to look at and see and easily stage. You can appreciate the neovascularization so easily. But then when you have a retina that looks like this, it's so quiet. It almost looks like something else should be going on. And yeah, that ischemia, there's that neovascularization too. But this could easily, you know, if you weren't looking close enough, again, you could easily call that mild. But so again, very important to overdiagnose versus underdiagnose. So what about managing these patients? Okay, great. We detected them, we classified them. Now how do we manage these patients? So very importantly, when thinking about managing these patients, remember that these patients could present at any stage. You never know what you get with the diabetics. You really don't know. Someone could be diabetic for 15 years that they know of, have nothing. Someone just got diagnosed and they have quite a bit of disease. And the ones that have disease, they usually think, and it's affected their vision. They think, oh, I just need glasses. Glasses is the thing that's going to fix it all. So here's a patient. This patient is actually suffering from chronic disease. And what's one thing that tells us it's chronic? It's the exudates. Okay, these exudates tell us it's chronic. But this patient just thinks that they're just coming in for their first exam here. This patient did not come for their follow-up. They were supposed to come back. This patient did not come back. And at this point, when he did finally come back, he's had further progression. He was previously asymptomatic. Now he's definitely symptomatic. No glasses will not fix you. Look at all this edema that this patient has here. So this patient started from a place that if he had better control, could have avoided all this, but no. Now he has actually severe disease that will require treatment. So very, very notable to know that this diabetes it's a chronic disease. It's progressive. It's not a temporary thing. It's a forever progressive disease that we need to manage as such, and also let the patient know. So with that, I'd like to take it to our next poll question.
All right. Polling question is open. And it is, which of the following is a definitive indicator of proliferative diabetic retinopathy? Intraretinal microvascular abnormalities, neovascularization of the disc, cotton wool spots, or capillary non-perfusion? Which of the following which of the following is a definitive indicator? These are two different polling questions we have up here. I'm looking, so I'm not sure which one is where that one came from, but the one that's been launched is, which of the following is an urgent referral? Center involved, severe vitreous hemorrhage, or neovascularization of the iris? Which of the following requires an urgent referral? So that's the one that's been launched. So that might be my issue whenever I put them in.
I think you jumped one, Greg. We should be on number 4.
Oh, okay. Well, I got number 5 launched right now, Roya, sorry.
Okay.
We'll see what the answer is here, and then we'll go back and launch the other one. So whenever you get, we'll do 5 instead of 4 and 4 instead of 5. Sorry. Getting sloppy on my polling tonight. So which of the following is an urgent referral? Center involved, severe vitreous hemorrhage, and neovascularization of the iris. Neovascularization of the iris 1, along with vitreous hemorrhage being 2. I'm sorry, that's 3, and center involved is number 2. So, all right. Close the question. I'll display it. I'll close it. Okay. So I'll do the other polling question, this polling question the next time. You're good, Roya.
Oh, okay. Any questions, Dr. Salka?
Nope, you are good right now.
Oh, okay. Well, great. So how often, when we're managing these patients, how often should we be seeing these patients? So there is the ADA guidelines, which we're going to go over, but then those are just guidelines. Really, you should, I would say every patient is unique and every patient should be managed depending on several factors, but not limited to the type of diabetes that they have. As I mentioned earlier, the duration of their disease, how old the patient is, because remember earlier when we saw those graphs, the incidence of diabetic retinopathy increased with the older each patient got, their level of adherence to their treatment, and their understanding of their treatment plan. And I'll explain later why that's important. If they have any other medical conditions, such as, if you have the patient that also has sleep apnea, hypertension, high cholesterol, kidney disease, all these things, very important. And then also both their non-retinal and retinal ocular findings and symptoms. So if they have, in addition, they have like really bad dry eye, diabetic keratopathy, or other ocular surface things, all of these things will change how you manage these patients. And then their subjective changes in vision. So according to the ADA, this is the ADA guidelines, an adult with type 1 diabetes should have a dilated comprehensive eye exam 5 years after the onset of diabetes. Now that seems kind of surprising. Why 5 years? Well, because, a person who found out that they're type 1 diabetic, that's when they became type 1 diabetic. It's not like they've been living with this disease for a while, so they immediately become type 1. And assuming they get on insulin and treatment before anything could really happen, it's within 5 years. Still, though, fortunately, I would say a lot of primary care doctors, endocrinologists, they are still great about getting these patients in to be seen sooner. So, whereas a patient with type 2 diabetes, they should have their initial dilated eye exam at the time of diagnosis. The reason that's important is someone who's a type 2 diabetic could be diabetic for 5 years, 10 years. They may have just gotten diagnosed. Chances are, though, they've been diabetic for many years, and so they could have any level of retinopathy. Like I said, it's a smorgasbord with a type 2. You don't know what you're going to get. So it's important that they get their eye exam right away. And then it goes on to say if there's no evidence, you can see the patient every 2 years may be considered, but if there's any level of diabetic retinopathy for either type, it should be repeated at least annually, and if it's worse, should be seen more frequently. So we'll go into that a little bit more in depth. What about our pregnant patients? Any pregnant women with a type 1 or type 2 who are planning should have an exam hopefully before they become pregnant, to really be counseled on the effect of diabetes on the eyes, and if they have any type of retinopathy, the effect of that progression. Usually that puts them more at risk, because the body is just doing so much. So basically the vessel, the woman's body, that everything's given to the child, the body certainly takes a beating. And that's why a lot of diabetic patients don't have children, or are encouraged to limit the number of children that they have. Similarly, if they're already pregnant, then they should have an eye exam within every trimester, and then for 1 year postpartum, depending on the amount of retinopathy. And then very importantly here, I like this note from the ADA. Granted, this is from 2017, but it actually has not changed. It says, while retinal photography may serve as a screening tool, it is not a substitute for a comprehensive eye exam, a comprehensive dilated eye exam that should be performed at least initially or at intervals as recommended. So this is the ICO recommendations. Again, same type of thing. So you have this patient, if they have no retinopathy, they're mild, you should see them about 1 to 2 years. I personally see all patients every year, regardless, normal, diabetic. If you are a diabetic patient, though, and you have very poor control, I will see that patient sooner. And a big reason for that is when a patient, remember we said patient lack of understanding of their treatment plan, patients don't really understand the severity of this disease, especially when they're younger, in their 40s or 50s that they get it, early 50s, they still sort of think it's not a big deal. So whenever you're seeing the patient more, they start to sort of take it more seriously. Oh, this must be serious if my doctor is choosing to see me this many times. So that's another way that I personally convey to patients the gravity of this disease if it's not well controlled. Mild, you want to see them 6 to 12 months. Moderate, 3 to 6 months. You choose to follow a severe non-proliferative patient, you should see them, I would say at least every 6 weeks, but it says less than 3 months. But really according to ICO guidelines, it recommends that you should start referring within at the moderate level. I will tell you, some doctors, again, some doctors, there's a new paradigm to start treating at the level of severe or even moderate, or severe moderate, or high risk moderate is what they call it. But this really all depends on, again, your level of comfort and your level of and your communication with the retina specialist. Very important thing, which I forgot to mention earlier, that I want to make sure is not lost, that macular edema, it can present at any stage. At any stage, it can present whether a patient has mild, moderate, severe. So macular edema can present at any stage. And when you see that, that should warrant a referral. And I'm going to bring it back to something I mentioned earlier. So if you have a patient, diabetic retinopathy traditionally seen in the posterior pole, but if you have a patient with predominantly the disease showing up in the periphery, that should be a cause for concern. These patients have been, in studies that have followed these patients, they have found that these patients progress to severe and proliferative disease at a much higher rate. And what's the difference? It's because in the periphery, you have these areas of non-perfusion. So if they're having this non-perfused area that's already having these diabetic changes, on top of that, these patients usually have high blood pressure that's also compounding the issues. And one other thing, I'll have patients that are not diabetic, or maybe don't have high blood pressure, or maybe just borderline, but they'll also have peripheral hemes. One of the things that, and I can tell you unilaterally, I have sent all of these patients for sleep screening. All of them unilaterally I've received a letter back that this patient has some form of sleep apnea. So if you also see peripheral hemes in a normal patient, otherwise normal patient, suspect sleep apnea. But in a diabetic patient, if you see peripheral hemes, and even though this patient, it would be typically a mild diabetic retinal, mild non-proliferative diabetic retinopathy, I would see this patient much earlier than a year, because chances are this patient will progress much sooner. So back to follow-up and expectations. So with our pregnant patients, again, they should be seen hopefully before pregnancy and then within every trimester if they don't have any retinopathy. If they do, they should be seen in closer intervals. Very important for our patients that will have, if they have cataract surgery, because diabetes progresses, progression of cataract increases, especially for those on insulin. If they have any type of macular edema after cataract surgery, they will get more macular edema. So very important to follow that closely. And then usually the cataract doctor, depending on what your follow-up protocol is with them, make sure that you also speak about this with your patients, because again, a lot of times they think, hey, I'm going to get cataract surgery, I'll see great, I won't even need glasses, and they'll forget their follow-up. Very important to talk to them about the importance of following up with you. I actually make them those appointments. I don't depend on the cataract doctor to send them back to me. So when to refer these patients? This is the general guidelines. If you have any macular edema, if you have severe NPDR, if you're suspicious of neovascularization, because I will tell you a lot of severe NPDR patients, it is hard unless you're really, really looking to find neo. And if you don't see it, they're going to get it pretty quickly. So severe NPDR, usually if you're suspicious, send it on in. Any type of proliferative diabetic retinopathy, vitreous hemorrhage, tractional retinal detachment. And if you have an NVI, any neovascularization of the iris, that's an urgent referral. These patients will be treated different ways. Either they're still, can get a laser, anti-VEGF. If they have, they may get a vitrectomy. There may be different combination treatments and even steroid injections as well. Very importantly, and this is something that sometimes patients really have a hard time. How many times have you had a patient that said, my vision wasn't that bad until I started getting those injections? Why does that happen? That happens, and this isn't a perfect example of it. This is a patient that was sent with macular edema. You can see that this edema is improving month after month. But what's happening is that when that fluid that fluid kind of closes up, it turns into exudates. And exudates are actually harder for that light to go through. So yes, that patient will have a harder time seeing with exudates versus that initial edema. So a lot of times, again, this is why it's so nice that we have all these visual things that we can show them that they're actually getting better. And in the long term, this patient will actually do better. When you're sending a patient to a retinal specialist, it's important to educate the patients, but not necessarily, I don't always tell the patient, yes, you're absolutely going to get a injection, because I don't know that they will. Sometimes, like I said, depending on several factors, insurance and other things, that patient may not necessarily get an injection at that point. I've learned, I can sort of tell at this point who will and who won't, but I don't, so that's why I don't say preemptively. And this is just with working with my particular retina specialist, but, and then very importantly, we like to tell them that they will get their vision better, but we actually want to preserve the remainder of their vision. So it's really more about stabilizing their vision rather than restoring their vision. And with that, can I take it to the other poll question, Dr. Caldwell?
We can. So we already did this one. So I'll just launch the other poll question and then we'll be all caught up. So and I'll read it. So this is now, since I had them out of order, which of the following is a definitive indicator of proliferative diabetic retinopathy? Intraretinal microabnormalities, neovascularization of the disc, cotton wool spots, capillary non-perfusion. That question should be open for replies. Which of the following is a definitive indicator of proliferative diabetic retinopathy? And I apologize for getting them out of order.
And when the responses are coming in, Roya, a question came about any concern with type of dilating drop used for the pregnant patient?
No. I get this question a lot. Should we dilate the patients? Absolutely. Absolutely dilate the patients. There's more benefit to dilating the patient than would possibly be any harm. Have the patient punctal occlude very well, but yes, absolutely dilate the patient.
Any concern with a patient who, and this is my question, and I have my own philosophies, people who are breastfeeding?
Again, no concern, not at all. I personally dilate the patients with tropicamide only. I don't use any of the other drops, pyramid or anything like that. That's been my drug of choice. And it's been a very safe drop to use. I wouldn't say that, and maybe you can educate me here, Dr. Salka, but I don't recall really hearing anything terrible about the other ones, but caution to use. But tropicamide is widely available, so tropicamide probably the safest to go.
I agree, because tropicamide will give you a dilation. Phenylephrine alone will not do it. I don't hesitate to use both of them, and many retinal specialists use 10% neosynephrine. And I guess you can always extrapolate that to what about the hypertensive patient who is also diabetic? Are there concerns? And my belief, and in the literature supports this, is when you have 2.5% phenylephrine, there's no adverse cardiac events either. Now, 10% neosynephrine might be a different story.
I always find it interesting how we are so cautious, but I feel like our colleagues and the ophthalmologists and certainly retinal specialists, it's not even, there's no pause on their part, because
Roy, I agree with you. I agree with you completely. I'm going to go on my soapbox for just a minute. One of the greatest antibiotics that we've never had, that we've never used, is chloramphenicol. Yeah. In Australia, it's over the counter. Any mother can walk into a drugstore and get chloramphenicol for her kid. Not a problem. They laugh at us.
Yeah, I mean, with regarding the breastfeeding, you know, I would say yes, go ahead. I'm not going to have any problem dilating an infant coming in, either with phenylephrine or tropicamide. So, I mean, if I'm not worried about putting it in the infant's eyes, I'm certainly not worried or concerned in a sense about, the mother getting dilated that's breastfeeding. You know, even the same rule would kind of go into play there if someone's pregnant. You know, if the baby was premature, we would dilate them. So I think they're pretty safe medications to use. Which of the following is a definitive indicator of proliferative diabetic retinopathy? Roy, I know they're out of order here, but 8% went with intraretinal microabnormalities, neovascularization of the disc won by 83%, cotton wool spots was 2%, and capillary non-perfusion was 7%. So 83% neovascularization of the disc.
Very intelligent audience. Very good. Okay. One thing to know is once these patients actually get the treatment, you're going to actually, when you see these patients back, you're going to see some vascular reversal and remodeling. I mean, just look at how after treatment, post-treatment, a lot of these patients will look. So a lot of that, so just kind of note that. We certainly take photographs, which are so helpful, but very important. So when managing these patients, again, make sure you have the right tools to detect these conditions. If you don't, I highly recommend referring to a colleague into referrals. There are colleagues like myself who like to see these patients. So referring to these colleagues, and then make sure if you are detecting and seeing these patients, make sure that you're classifying the condition correctly. Consider all the factors associated, both ocular, non-ocular findings. Follow up according to the standards of care. If you are referring, know who and when to refer. And this is very, very important. One of the most symbiotic relationships with our ophthalmology colleagues is with retina specialists. And I always say that if you cannot text your retina specialist, you should find another one that you can easily text and ask a question. Say, hey, do you want to see this patient? How soon do you want to see this patient? Because one of the things that we often tend to do is, and that's why I had that last question as the last question, which one is a truly urgent referral? A neovascularization of the iris is truly urgent versus, macular edema. It's not truly urgent. You want to get them in there within a few weeks, like 2 weeks or so, less than, but it's not truly urgent like neovascularization of the iris that they need to be seen within like a day. And then I'm going to go, a little bit and really, really highlight patient education, because this has been the one crux of this whole thing that, we can talk all day about how to detect well, how to classify well, all these things. But if the patient is not understanding what this disease is or what it's doing, then all of that is just really, I don't want to say pointless, but the patient really needs to understand it. So what could have prevented this patient from, with that one microaneurysm that we saw earlier, to going into this? In this particular patient, I really believe it was education. This patient did not understand the gravity of this disease. And this is sort of a review, and I really, really love this study here. And this was a review of barriers to people going to get their diabetic eye exams. And it's the same thing for the regular comprehensive eye exam. It's the story we have heard over and over. People don't go because they don't have insurance. People don't have, it's a financial barrier. There's no eye doctor nearby. Well, this study, this is for diabetic patients only. And you can see by like the little pointers, like what sort of was the main reasons. So right here, yes, a big part of that, this big part is low income, financial barrier and cost. But look at these other ones. Look at these other kind of things. This one right here, it says lack of knowledge, lack of awareness, asymptomatic nature of the condition. These are parts, these are things that we can address. These are parts that we can address. So patient education, when it comes to right here where it says symptomatic nature of the condition, this is going back to what patients have been doing for years. Why do you not get an eye exam? Well, because I can see just fine. No, vision is not an indicator of the presence or absence of your retinopathy. It is not. You can have retinopathy and still be able to see 20/20. Patients must know that, hey, and this is the part where I actually kind of, it's not so much them coming to see me every year annually, it's when I have to send them to the retina specialist. They think that after one treatment, they're fine and they're good and they don't go back. I know this because I have learned over the years, when I make an appointment for the retina specialist, I also make an appointment for them to see me as well. Because again, these patients, they may have diabetic retinopathy, but when I send them off, I'm probably still managing their dry eyes or something else that's going on with them. And more importantly, I like them to see me just to see how that's going. And I'll find that they have missed appointments either because they received an injection or a treatment and their vision's fine. They don't think they have to go back. They don't understand that this is kind of a series of things. They think one treatment and you're done. And I have to always bring it back to, well, your high blood pressure, do you take one pill and are you done? Or, you know, even your diabetes, one pill, no, it's a chronic lifetime type of thing. He needs continuous care. So it must understand that how important it is for them to continually be monitored. And that's the only way that we can avoid those, what we call disasters. So when you're talking about patient education and self-management, I always go back to the ABCs. Know your ABCs. So know what your A1C is, your blood pressure, and your cholesterol. I will say that with the advent of electronic health records, that has been much easier, certainly in my setting, which is an academic medical center. I can easily, if they don't remember their numbers, I can easily pull up their last labs. But it's, but we know that patients who measure or who are their numbers, they usually better as well. They're usually better controlled. I think we say this in business as well. What's the saying that goes, what you measure, you can change? What's the saying or something? It's in business as well. Like whatever you measure, it'll come to me later, but it's the same thing. Whatever you measure, you can improve or change. Blood pressure, 130/80 is not ideal, but it's good for a lot of our diabetic patients. That's what's considered. And then of course their total cholesterol, very important. Know very importantly that all these things also get worse as the patient gets older. And I want to talk about, again, back to their control. Remember earlier I said that the amount, once they have any form of diabetes, and any form of retinopathy, what's more important is their control, not so much how long they've had diabetes. And this is two different studies that I'm going to go over. This one showed that for every 10% decrease of the patient's A1C, there was a 40% decrease in their risk of diabetic retinopathy. And that's significant. That's like from a patient who's like a 10.0, you know, getting it down to a 9, you know, they decrease their risk by 40% each time they bring it down 10%. This is another study that showed that this is the opposite kind of study that showed that for patients, for every 10% increase in their A1C, they increase their incidence of getting diabetic retinopathy by 64%. So that's very so, you know, it's not a very small thing to control their blood sugar. It's, again, gives the patient, I always present it as a way to empower the patient. Listen, this is something you have control of. You control it. This is the projection. You will do this much better. And then finally, this multidisciplinary approach to diabetic eye care. You want to make sure you are familiar with the patient's primary care physician, if they have an endocrinologist, if they work with a regular ophthalmologist, yourselves, and a retina specialist. Very important to collaborate with these patients, that they know what level, how often being seen. Again, another thing that I love about electronic health records is that anytime you go to a primary care doctor, they'll ask, have you had your annual eye exam? And if the patient says no, it automatically sends in referral, it generates a referral to the eye doctor for an comprehensive eye exam. So I really appreciate that. But establishing that relationship with the treating providers, you know, when I first started at our academic medical center, I wasn't getting a lot of the referrals. And that was my fault because I hadn't learned the system and I wasn't writing those letters back to those doctors. Once I started generating those letters, learned how to do that, I started getting much more referrals. Earlier, I mentioned the sleep specialists that I've been getting letters from. It's very nice to see those patients back because the sleep doctor actually is always surprised that an eye doctor saw signs of sleep apnea in their eye, and the patient ended up, who, you know, wasn't a patient, this particular patient wasn't the traditional sleep apnea patient, didn't have like a thick neck or didn't, but certainly, you know, if I saw that peripheral theme, I was going to send that patient. So creating that reputation and then follow up on those referrals. I know when I send a patient out to anyone else, when I get that letter back, it just makes that relationship so much stronger. When you're looking to managing these patients, again, be honest with your level of comfort. If you don't have the right tools, this may not be a patient you see. You may see them for their dry eye and maybe for their contact lenses, but stress the importance of seeing another or refer them to another provider to do their comprehensive eye exam with dilation and additional testing if needed. And then, again, having the proper diagnostic tools. This question, I added this slide because this question actually came up at our the Scottsdale meeting earlier this year, and I was very impressed this person asked this question because this is very important to know. So we've been hearing a lot about these new drugs, Wegovy, Ozempic, and things. So right about the time of this meeting, this study came out. It was the Sustain 6 trial, and it found that these new drugs, GD1 agonists, were causing an increase in diabetic retinopathy. And is that something we should be concerned about? Since then, there's been 2 other studies done. One found that there was really no change in diabetic retinopathy, and another one found that there was a decrease in diabetic retinopathy. These were more real-world reviews, and what that means, they had followed these patients a little bit longer. And what it can be attested to is what we've actually known for a long time. Any time that you have a patient, and this is, you have a patient that is very poorly controlled and they suddenly drop, like there's a sudden drop in their control. So you have like a 12 and they suddenly drop to a 6, you're going to see a little bit of retinopathy, just as sort of the body kind of comes to that homeostasis is what I call it. So that's really the most of the difference that we've been seeing. It has really not been cause for concern for anyone to tell anyone to stop taking medications, because they're actually, what are they doing? They're helping these people get in control, and they're doing what the other studies have found, which is get that control to a better level and have better overall control. One thing that has changed in our practice is because these medications sort of slow the kind of how food, this is why these patients stay full for so long. They kind of slow how food moves through the system. If a patient is about to have surgery, they have to be off this medication for a week. That's one thing that has changed on the surgical side. So I just want to note that. Dr. Salka, Dr. Caldwell, any comments on this in particular?
In this or in the presentation in general? Are you close to being done?
Oh, yeah. Well, no, this one came up, if you recall, in our
Okay.
Scots.
Mhm.
It was good discussion that we had that day. But I don't know if you've seen anything from your practices or anything that says anything different from the patients on these medications.
I have not seen anything different in the real world.
Okay.
Greg?
So my comment will be is that we have to remember everyone's an individual. And that's why I think you'll see with these medications, you see an increase in diabetic retinopathy, you see no change in diabetic retinopathy and a decrease. Usually diabetes is one part of probably the metabolic syndrome. You got different stages. You got different years, different, chronicity of the patient. So I think that's why, it's hard to say that when we use these GLP-1 agonists, that you're going to get this result. I think it's going to be the mix of results that you have listed here, because remember, diabetes is a chronic lifetime disease, and who knows what part of this chronic lifetime disease we're plugging into. We had Paul Chouse on just recently, and one of the things I picked up on that you said is when you have that sudden decrease, and he really highlighted in his talk about it's the hypoglycemia that really creates that risk of diabetic retinopathy worsening. They talked about hemoglobin A1C and all this stuff, but it's like time in range that is important that's out there rather than, maybe the hemoglobin A1C. But when the time in range drops below and then we get to that hypoglycemic, that hypoxia and poor nourishment to the retina creates that retinopathy. So it's probably that kind of that association that you just said there. If their hemoglobin A1C is 11 and they drop to a 6, that's a pretty drastic drop. They were probably hypoglycemic, and that's what caused the retinopathy to occur. So, those are some cool things with these medications. We're seeing some remarkable things with them, but we're also seeing some complications with them outside of the eye. But that's, medicine, it's a double-edged sword.
Right. And like any of these medications, it's time would really tell the long-term effects of all these things. So it's just something to look out for. One thing that I personally have changed is I have changed how, how often I will see these patients. So whereas, oh, okay, great, your A1C is dropping, I might see you, maybe another 9 months out, I'll stick to my 6-month rotation and see these patients. And I can't stress enough, and I mentioned it earlier, the guidelines tell us, see a patient with mild retinopathy or no retinopathy within a year. How much that's just a guideline. Really, it's just like Dr. Caldwell said, it's very patient specific. The patient's poorly controlled, older in age, has other things. You should really be seeing those patients on a more closer increment, not only to catch any retinopathy early, or any advancing retinopathy early, but also to really, it again helps the patient understand how important it is that this is a chronic condition that needs to be managed, and therefore seeing them and how important it is, again, catching it and developing that relationship with that patient. So when I see these patients, don't rely on your vision to decide when to come in. Really don't. Another thing I genuinely deal with a lot, I think this happened a lot on the heels of COVID with the shortages in medications. A lot of patients not only were not coming in, but also had not taken their medication. So I had a twofold issue, and really getting those patients back into being seen as often as they should have been seen. A lot of that progression of diabetic retinopathy. And believe it or not, I'm actually surprised at how many patients not getting their medication wasn't always due to supply chain issues. It was a lot of times due to certainly financial issues, but, I actually have said, gotten in contact with their PCP, find out a way to get that medication to the patients, calling the companies, because again, knowing the importance of how well they're controlled matters and how they progress in their retinopathy. And then I want to stress one more thing. Tonight, we are talking about retinopathy, but we have to understand the eyes, what's happening in the eye is happening in the rest of the body. They just don't have the ability to visualize it with simple dilation like we do. So what's happening at those levels is happening within the rest of the body as well. And that's one thing that I always tell the patients as well, because sometimes they think, this is just happening in my eyes. No, this is happening in your kidneys. This is happening in other things. They might miss, their eye appointment, but they won't miss their dialysis appointment. But then they fear going, because I can understand that, if you don't go to dialysis, you could die, but or you could live blind. You got to sort of pick. But very importantly, to tell them that what's happening at the eye level is happening in other parts of their body as well. Control of A1C is not a treatment for diabetic retinopathy. So they still need to take their medications. I don't know sometimes how different populations are, but a lot of patients are resistant. Certainly in my population, to sometimes take this medication. They don't understand it. Type 2 diabetics in particular, which ones, the ones that have to take the insulin, not so much, they're a little bit better, but the ones with the medication, and I sort of have to tell them, you have the insulin in your body, but it's not working. It's sort of like having an employee that's not working. So whenever you introduce the medication, it sort of activates those insulin cells to sort of do their job and clean up the sugar from the bloodstream. So a lot of times it's their level of understanding. And I can't tell you how many times patients have said to me, no one has explained this to me. So understand that it's not them controlling their A1C is the best thing that they can do for the progression of their diabetic retinopathy, but it's not a treatment. They still, if they have to go see the retina specialist, they still have to see the retina specialist, get those treatments, and it will be a series of treatments. And with that, I'm going to add, if you do follow these, don't just, never see these patients again. You should continue to see these patients, to follow up with them. You've established that relationship with them. They have other things that they need to be addressed, whether it's refractive changes, dry eye, maybe, and sometimes even more serious things too that you could catch that maybe retina's not looking. Remember, and this probably happens to me the most, I'll have a patient from retina coming to me for the first time, and they've been treated from some type of retina condition, but retina has completely missed the glaucoma diagnosis. They're just sort of, when you work with ophthalmology, they're sort of in their lane, in their world. And so retina is very much focused on versus glaucoma versus the other specialty. So, and it's really us who sort of really look at everything in the eye, and don't forget the very important part.
Yeah,
Remember,
I've always found it very curious how in retina practices every patient has a 0.4 CD ratio.
yes, very good. Yes. Yeah, they're and you have to remind them, the optic nerve is in the retina, but they're just, They may be interested in some neovascularization on the optic nerve, but for the most part, they miss a lot of those glaucoma diagnoses. Same thing with a lot of the screening tools that are used. If you are in a location that the PCP has a screening tool for diabetic retinopathy, a lot of those patients, if you've ever seen them, they'll tell you that they got a picture done at the PCP's office. This is using artificial intelligence that, it can usually grade it, tell them if they have retinopathy or not. It's very important to know that that AI algorithm is only looking for diabetic retinopathy. It's not looking for glaucoma. It's not looking for cataracts. It's not looking for the other things that patients could have. So yes, the patients still need to be seen by a physician and have a full comprehensive eye exam. Remember to tell your patients that poor controls progression. They will also have a poor response to treatment. And then they'll also have progression to other comorbidities. One notable thing that I think I've seen over the years is a lot of diabetic patients, when they have cataract surgery, if you notice how their lens looks in their eyes, how they heal is very different than a healthy patient. So a few other things to look out for. Again, emphasize that this is a chronic condition that will need chronic care, similar to other diseases, high blood pressure, which they'll probably have, high cholesterol, all those things. And now I think so remember, diabetic retinopathy, it all starts with one little microaneurysm. It could lead to a disaster, and all of that is preventable. It really is all preventable. All right, I think we're landed just on time. 100 minutes. Okay.
I think we got a minute or two for some discussion. I've looked, there are no new questions. So Roy, if you can back up about 5 or 6 slides to the right there, perfect. It was right, no, the one you just had.
This one here?
Right there is a multidisciplinary approach to diabetes. In that upper left graphic, obviously the most important person in it is the patient. That's number one. And you can educate and educate them. And there are some people that really just have a lack of survival instinct, a self-destructive instinct, and you're not going to get through. We're not going to get through to them. But outside the patient, it's not the retina specialist; it's the PCP. And the reason I've come to realize that is I spent most of my career in academics, where I saw a lot of patients who were uninsured, underinsured, and they didn't really have a relationship with a primary care physician. They knew they were diabetic for the most part, but there really wasn't a lot of care. They didn't know their numbers. They didn't know their blood sugar. They're always cagey about when their next appointment was or is upcoming. And I saw a lot of blindness from diabetes. I mean, it was not uncommon to see the tractional retinal detachments, the proliferative retinopathies, the neovascular glaucomas. It was just part of my daily routine in academia. Now I've moved to a ODMD medical surgical practice, a very large group, and I see a lot of diabetics, but I see a relatively low degree of diabetic retinopathy, and it's because of the PCP. They've got a relationship with, and I think the best thing that we can do is enhance and support the relationship with the PCP. I think this past week and I didn't see it, my wife saw the patient, probably the first good proliferative diabetic retinopathy we've seen in a long time. And it was not the typical patient that we see in the practice. I forgot what the demographics were, but it was more the academic patient population. But when they have a good relationship with their primary care physician and their PCP is bugging them to get an eye exam, of course, our EHR is easy to do, to dictate letters and send off letters. They need that letter, but that relationship with the PCP, I found has been the biggest difference in reducing blindness from diabetes. When they have a good relationship with the PCP and they're getting the exam, and if there's an endocrinologist on board, that's great. They need the letter as well. I'm just not seeing that much fortunately, not much retinopathy. Whereas when that PCP is not involved or they're not consistent with that PCP, I saw a lot of blindness. So that really is I think the key factor is working with the PCP and educating the patient, that they're doing the right thing by going to their doctor.
Yeah, and you're so right, Dr. Salka, because just this past year, I actually graduated with my second doctorate in health administration, and my research thesis project was on why people don't get their comprehensive eye exams. I picked an educated population for my study population. These were people who had insurance, access to eye care, and were all educated. They worked in healthcare. The number one reason that they did not get an eye exam was because they see just fine. And the number one source that they named, if they would like as a source to stress the importance of an eye exam, was their PCP. So you are very right about that. They really showed like how important the role of the PCP is in sort of mitigating that relationship and helping patients to understand that an eye exam is much more than assessing your refractive status. Yeah.
And this is going to show a couple slides here, Roya, just so that we can just stay COPE compliant, probably take 2 or 3 minutes here. And basically just to kind of highlight what you were going off with your OCTA and your foveal avascular zone, maybe a normal avascular zone is kind of tight. You can see the expansion that's happening here in a microaneurysm, as you kept pointing out, as one of the early parts of diabetic retinopathy, where we as optometrists or ophthalmologists or eye care physicians, doesn't matter which side, would maybe say that this is no diabetic retinopathy. Now, the question that usually comes up to the audience is, would you consider this, diabetic retinopathy? I'm not asking you, Roya, but the audience would typically ask, can I call this diabetic retinopathy? And the answer is yes. You can call that diabetic retinopathy. You can follow it because it is diabetic retinopathy. I think we know diabetes is a capillary disease. So that's why looking at the capillaries is pretty, is now considered, one of the treatments or one of the diagnostics that we could do. And that's why I think OCTA is catching on. OCTA works well with diabetes. Obviously, it's a capillary disease, macular degeneration, and it's pretty good with glaucoma. It kind of gives you another tool if you're trying to scratch your head on progression. I'm watching the time here. We'll go about another minute or maybe another minute or two. I like this one here because the blue lakes are showing the ischemia, the capillary dropout. And then we have the B scan down here on the OCT. And we can see how much ischemia has occurred. And remember, I was pointing out that the inner retina, outer retina, there's kind of this loose space right here. And I look for diabetes in this area when I'm looking for diabetic retinopathy. And we might start to see a little change here, but for sure you got a hemorrhage or an exudate popping up here. And we would say, okay, now we're starting to get diabetic retinopathy, but look at how much ischemia had occurred. So, I have OCT angiography in my practice. OCT angiography is wonderful. It complements the B scan really, really well. I think they're both important. I've picked up, retinopathy with the B scan maybe before I would see some ischemia, but most of the time there's ischemia going on, but it's just a nice little adjunct to have. So, here's a patient, that comes in. We do these kind of wellness exams. I like looking at the GCC. I like seeing what's going on with the capillary. I can tell you that these there's no normal size to that foveal avascular zone. The OptiView, which is now Visionix, is able to measure it. I'm not sure if the other OCTs can, not creating any kind of superiority out there. But I like having this measurement because when they start becoming asymmetric, it's usually the one that's expanding. Now, these are pretty close. I would say about a 10 difference. Then we start seeing, look at the larger one, you're probably getting expansion. As in this patient right here that came in that we did the wellness on, you can see that this one is 35 and this one's 20.0.35. You can see the expansion here. You can see the dropout in the areas here. And we were able to pick up diabetic retinopathy. As you can look, this retina in the B scan looks pretty clean. The photo looks pretty clean that's out there. So again, just using OCT and kind of pulling all the stuff that Roya talked about all together. And this is just another case of the foveal avascular zone expanding. You can see the capillary damage that's happening. And just a third case now where the symmetry is good, but look at the retinopathy that we can pick up. So they both complement each other really, really well. You can see here some of the exudates and hemorrhages. You can see the capillary changes. You can see what's happening down here in the OCT. Again, this is the area, that loose association. Everything's going to kind of pull between that inner and outer retina. And we certainly don't have to do this case because it looks like we're pretty good on time right there. And we nailed it. And Roya, I want to thank you for, a great overview of diabetic retinopathy. I'm going to have Joe make some comments, but I'm just going to share with the audience right here. You see that there's a little red dot now. You can open up that survey and start that survey. So with that being said, this was diabetes, retinal disasters. Joe, did any other questions come in?
Not in the last minute or two, but I'm going to take a quick look. No, Roy is getting here a virtual round of applause and thank you for great CE. And I agree with everybody who was saying this. I think it was terrific. It was very expansive, and I thought it was a great roadmap to try to help patients preserve their vision through prevention. So, Roy, thank you so much. We really appreciate you doing this for us and for our audience.
Thank you. I really enjoyed it. Great to see you both too.
Good seeing you as well.